My friend David told me this story. When he was a resident in the emergency room, one night he and 2 other residents were wondering why the dinner they had ordered hadn't come yet. Suddenly a nurse shouted, "GSW, trauma 1, no pulse, no blood pressure." And the residents immediately recognized the gunshot victim on the gurney. It was the teenage delivery boy from their favorite all-night restaurant, and he had been mugged delivering their dinner. That made them work even harder. A surgeon cracked the kid's ribcage open to expose his bullet-torn heart, but they couldn't even stabilize him enough to get him up to the operating room. So after 40 minutes of resuscitation, they called it. Time of death, 4 a.m. The residents stumbled into the temporarily empty waiting room and just sat in silence. Until David said what all 3 of them were thinking. What happened to our food? Joe went out and found it. The pizza box was right where the delivery boy had dropped it when he got mugged, feet away from the emergency room's sliding doors, face up. Joe brought the pizza box in, set it on the table, and the residents stared at it. How much you think we ought to tip him? The residents laughed, and then they ate. Now, my friend David finished his residency 15 years ago, but when he told me that story, it was like it had happened last night. "You're the ethicist," he said. "Was it wrong to make a joke?" I am a medical ethicist, and that's the kind of story that just grabs me because it's about moral distress. It's about the power differentials between doctors and patients, and it's about good people doing surprising things. And David asked the right question because medical ethics is a largely normative field, right? That asks the questions, what's the good thing to do? What's the right thing to do? Or among bad alternatives, what's the best thing to do? But I'm also in a field called the Medical Humanities. And I know everyone here is a humanities fan because you're here at a humanities festival. Raise your hand if you've ever heard of this subdiscipline of the humanities. A minority of people have. The medical humanities isn't about right and wrong. It's more interested in the what and why. And I'm in the Medical Humanities Program here at Northwestern. Our little shop is on the 6th floor of this building. You can come visit. And it's a multidisciplinary field with a shared object of study, the practice of medicine and the practice of illness. So our field includes philosophers, historians, experts in literature and narrative theory, performance studies, comparative religion people, medical anthropologists and sociologists, and lawyers like me. And we're not doing our work individually in separate departments. We're doing it together in a medical school department so we can borrow each other's methods to do interdisciplinary work, or what I think of as taking a problem in medicine and doing a 360 review. So let's use the methods of both medical ethics and medical humanities to think about gallows humor generally, and we'll try to answer David's question, was it wrong to make a joke, together. All right? So, why would physicians joke about life and death situations and the patients that they're here to help? After Freud did his dream work, he wrote a book called Jokes and Their Relation to the Unconscious. And in this book, he argues that the jokes we make are just as revealing as our dreams. The first function jokes make, according to Freud, is they help us avoid what he calls the internal obstacle. And Freud argued that the more shame, repression, and fear we feel about something, the harder we will laugh at a joke about it. So a good joke about topics like death, sex, religion, excrement, race, it's always going to produce pleasure by dodging the inhibitions of our prissy, civilized superegos that say, don't talk about that, and releasing the psychic tension through laughter. So jokes about things we're anxious about will always get a laugh, and probably in proportion to how anxious we are about them. And with death, there's a lot of anxiety. Freud says that the second function of joking is to avoid what he calls the external obstacle, right? Jokes are an alternative for fighting with a superior. When you can't tell your boss off to his face, the only option might be making a joke about his face. When you can't address your problems directly, that laughter is a more helpful response to that frustration and pain than anger or sadness. And if you can get other people to laugh with you, You might feel that your relative power to this superior authority figure has grown. A joke is a rebellion against oppressive authority. And what's more oppressive than death? Turning to philosophy, there's a University of Chicago philosopher named Ted Cohen, who's written a book that considers the existential reasons why we make jokes at all as human beings. Cohen uses the example of pointing out a beautiful sunset to a friend or a provocative piece of art. Why do we do that? Is it just because I'm such a generous person that I want to give you the gift of making sure you saw that sunset? Cohen says, no, that's not quite it. We're not quite that generous. It's a way to establish intimacy. So if my friend agrees that Guernica is very interesting, right, or that the Marx Brothers are funny, it means that we have something in common. We see the world similarly, and maybe you get me. Right? So in that sense, humor serves this vital social and psychological function of establishing a community of intimacy. Cohen also points out a second reason we make jokes, because laughing at absurdity is the only way to coexist with it. As Cohen puts it, when we laugh at a true absurdity, we simultaneously confess that we cannot make sense of it and that we accept it. Thus, laughter is an expression of our humanity, our finite capacity, our ability to live with what we cannot understand or subdue. And death is certainly something that we have to live with that we can't understand or subdue. Another analysis looks at humor as a form of rhetoric. Writer George Saunders says this about the dark humor in Kurt Vonnegut's war novel, Slaughterhouse-Five. Humor is what happens when we're told the truth quicker and more directly than we're used to. The comic is the truth stripped of the habitual, the cushioning, the easy consolation. This rapid truthing is what Vonnegut does with war. And I just love that term, rapid truthing, right? So let's apply that concept to a different example. There was a discussion of a newborn, not at this institution, who was neurologically devastated. And people in this group that were parsing kind of this number of angels on the head of a pin. I mean, just spending a really long time on all the different test results and possible outcomes for this infant. And it was circling and circling and circling until a neonatologist in the conversation ended the debate by saying, look, he's more likely to be second base than play second base. Right? I was shocked, as someone very young in her training, but it was interesting to see what happened rhetorically in that conversation. It served, people laughed and groaned, but it served to the function of moving the conversation forward onto the next issues, like what range of options should be available to parents in situations like these, right? It got people off of the like, well, what about this, what about that, the next test result, blah, 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 for another 30 minutes. From everyone else's reaction in that room, it seemed like they didn't disagree, with the content, the quote, truth behind what the neonatologist was saying, and it freed them to move on. So it may be an example of a joke serving that rapid truthing function, but I want to offer a more cautionary version of this from the rhetorical analysis. On the other side of that analysis, Freud again points out the danger of humor, which is it's a thought or an argument wrapped in a joke. Right? So as Freud says, while argument tries to draw the hearer's criticism over onto its side, the joke endeavors to push the criticism out of sight. There's no doubt the joke has chosen the method which is psychologically the more effective. So thoughts framed as jokes bribe and confuse our powers of criticism. If we laugh at them, by definition, we're not in critical mode. And if I say, wait, I want to respond to that joke with a rational counterstatement challenging its underlying suppositions, then I'm a drag. And everyone who's laughing will resent having to stop playing and to go back into critical mode, right? So positions promoted through jokes somehow seem stronger than those supported by arguments. And they have this built-in protection against criticism, which is, hey, it was only a joke. So I don't know exactly what that was an example of. I leave it to you, but there's two ways of looking at that. Turning to literature, gallows humor shows up in fiction also. The physician's classic is a book called House of God, a novel written in 1978 by a physician that follows the training of a fictional new resident named Roy. Now, Roy is green enough that he still has one foot in the lay culture that says this way of joking about patients is not right. And he has one foot in the medical culture that says you can't be exposed to this much death and behave in any other way. The book is funny and it is mean. But I want to point out to you historically that I think it makes sense that this book was written in 1978, because that era was the height of a peculiar kind of physician powerlessness, when they had a new ability to sustain life with new technologies like ventilators, but they didn't yet have cures for what put people on ventilators, or the legal authority to stop this non-curative treatment when families would say, you know, this patient's never going to regain consciousness. She would not have wanted this. Stop torturing her. They didn't have the legal authority to say, well, that's not murder. I can go ahead and withdraw this treatment if that's not this sustaining of life of something I can't cure, if that's not what the patient would have wanted. It was also a time, so they felt hostage to this technology in some ways. And it was also a time of fee-for-service, where hospitals profited from this kind of continuing treatment. So there was a lot of incentive to stop it. So underneath all the cruel and macho humor in this book, there's also this incredible underlying helplessness. Now, 1978 audiences were surprised to hear that maybe doctors actually talked like this behind the scenes. And reading it today, when it's even less acceptable to joke about vulnerable groups, it's even more shocking. But literary theory teaches us about the power of the narrator to construct truth. So the one time I taught this book, I invited students to rewrite passages where physicians were making fun of nurses or patients using the same facts. So if the fact of the scene was a doctor and nurse had slept together, you know, you couldn't change that. But to rewrite it, making the vulnerable person the narrator of the scene and having them make fun of the doctor, right? To reclaim that power of the narrator and understand something about the way stories are framed. Decades ago, sociologist Irving Goffman pointed out that all work groups develop a backstage language, and it's not meant to be understood by outsiders. So there's teacher to teacher in the teacher's lounge, firefighters in the firehouse, cancer patient to cancer patient in the support group, right? None of what they say backstage, when it's just us, is meant to be heard by anyone outside the group. And people backstage who talk like this might be very upset to find, you know, if anyone overheard them, because it wasn't meant for that. Some would argue that given what's at stake in the medical profession, demystifying physicians and giving insight into what happens backstage sometimes with books like The House of God or stories like the one I just told you, does not only not help patients, that hearing backstage language might actually hurt us, because those onstage roles are vitally necessary to make both parties in the medical counter comfortable, that we need these roles. So both you and your gynecologist can pretend it isn't weird that she has her hand in your vagina while you talk about the weather. Physicians aren't the only ones who joke about death. Two examples of patient humor that immediately come to mind are the films And God Said Ha, which is Julia Sweeney's humorous monologue film about the absurdity of her brother's fight with lymphoma and his ultimate death while she was also dealing with cervical cancer, and Spalding Gray mocking his eye doctor in the film Grey's Anatomy. But gallows humor typically occurs between peers. As I said before, the cancer survivor support to the cancer survivor in the support group, because of the danger inherent in crossing categories. Think back to Ted Cohen's community of intimacy idea. When a joke accidentally reveals that we don't see the world similarly, it can be painful. You know, who hasn't been in the situation where you're joking with someone and they're like, A, oh yeah, and B, oh right, and what about C? And oh my gosh, D, Z. And you're like, what just happened? Who are you? You know, how did you get to 20 steps away, right? This is terrifying, I have to leave the room. And it reveals that we're not on the same page, right? That's very threatening. So if your doctor successfully jokes with you about your medical condition, one reason it might feel good is because it actually puts you in a peer relationship for a moment. Going the other direction in the power differential, sometimes patients initiate a joke at their own expense. A colleague in another state told me this story. A thief escaping from a bank robbery crashed his car, and the police brought him to the emergency room for a trauma evaluation on his way to jail. And that includes a rectal exam. So my colleague expected the guy to object because a lot of the big tough guys he treats freak out about it. Instead, when he got to the part where he said, "I need to do a rectal exam," the thief looked out at the sea of cops and said, "I guess I have to get used to it." Okay, that's a joke about prison rape, which I put in the not funny category traditionally. And if one of the doctors had made that joke, it would have just been absolutely horrific, right? But Freud says we like it when victims joke about their own plight because it relieves us of what he calls the burden of sympathy. In this situation, it's interesting, it might have had the opposite effect because this very jovial doctor I know did not laugh when the patient said that. Instead, the joke made him feel more sympathy for the patient. It humanized him in a different way. When I asked my friend what happened in that moment, he said, "The joke bridged the us-him divide. Here's a guy who has the same dark sense of humor as me. It made me think perhaps in a different time we could be friends." Now, if that isn't Cohen's community of intimacy, I don't know what is. Medicine is an odd profession in which we ask regular people to act like feces and vomit don't smell, unusual bodies are not at all remarkable, and death isn't frightening. We begin their training by throwing normal 20-somethings into a room of dead bodies, and then we tell them to start cutting. Dissecting a corpse violates strong cultural taboos about how we treat the dead, and historically speaking, the anatomy lab was the site of cadaver antics, making jokes, clowning around with the cadavers, and pulling pranks to scare your lab mates. Until recently, cadaver antics were a rite of passage, an embrace of an alternate cultural ethos that said a doctor is a tough person who can laugh at death. Not just not cry, laugh. The concept of performativity is helpful here, a term associated with Judith Butler in the discipline of performance studies. What does it mean to perform a social role? How do you have to change in your training the way you look, act, and feel to, in this case, become a doctor and to be recognized by others as a doctor? And I think in the past, cadaver antics were a part of that acquiring the performance of becoming a physician. Today, they are absolutely no longer tolerated in modern medical schools. Instead, anatomy students are taught to imagine the lives of these people that these people might have had before they died. They're taught to journal about their emotional reactions to the cadavers, and they're given small groups facilitated by experienced physicians in which they can talk about these journal entries and their feelings. They're asked to think of these deceased people as their first patients and to treat their bodies with respect that patients deserve. And at the end of the experience, medical students often hold a memorial service for the cremated remains of the people they've dissected, where they write poems and they sing songs and thank these people for the tremendous gift they've given them in the course of their medical education. Now think about that for a second in terms of performance. That is a dramatic shift away from the macho, laugh at death kind of performance that's marking the role of doctor, toward compassion and connection with a patient's loss as being performative elements that help define the role of doctor. And I think in the anatomy lab, in this shift we've seen over the years, that by offering an alternate way of coping with this sadness and fear and tension that surround death, hopefully the modern anatomy lab experience models a different way to perform that role of doctor. So to recap, from our humanities tour, you're likely to find gallows humor in situations in which we have a community of intimacy, we are powerless, we need to release psychic tension, we're out of control, maybe we need distance to cope, or when it serves a functional shorthand, or it serves the role of kind of emperor's new clothes or court jester, speaking the truth to authority that no one else will. And that's fine, that's the what and why of medical humanities. But let's circle back and end by going to the right and wrong of medical ethics. What would make you even use the words ethical or unethical in relation to a joke? Well, first of all, I'd want to look at how the joke affects the doctor-patient relationship. Is the true target of the joke really a defenseless patient, or is it a doctor who's defenseless against death, decay, and chronic illness? Is the intent to be funny or to be a bully? Or is the intent to get through the day? You know, sometimes gallows humor can be a helpful defense mechanism because you have few other options in terms of time limitations or such. And other times, it's just a bitter objectification meant to distance the professional from exposure to suffering and the vulnerable people who rely on them for help. In her new book, Doctors in the Making, Suzanne Poirier notes the recurring theme of utter exhaustion in her review of medical student and resident memoirs. And she notes a pattern. Physical vulnerability leads to moral vulnerability. We are not our best selves when we are tired. And because ethics is concerned with protecting patients and families, I think who's listening to the joke matters. Even if doctors are telling the joke for the right reasons, if they say it in front of lay people, that could make that joke feel unethical to me. So think of David's story. If the delivery boy's mother was in earshot, right? That changes the analysis of it completely. And I'd also want to think about how it affects the profession, recalling Freud's external obstacle. Gallows humor doesn't turn underlying anger towards the real source of structural problems. It diverts it and releases it sometimes on the easy punching bag of patients. So I would want to know what's the underlying source of that anger or that frustration, and would it be more productively focused on addressing a structural problem? Is there an opportunity missed there by channeling it into and through humor? David and his fellow residents talked about that night several times over the 15 years that passed since he and I spoke about it. The overnight shift was brutal, they were hungry, and the delivery boy was already dead. But the whole thing made them sad for years. Wasn't that terrible? They'd ask each other when they talked on the phone. How could we eat the food that poor kid dropped? In the process of trying to do good, did they become bad? I don't think so. I think in that situation, a joke is the rock you throw after the bad guy's already gone, an admission of loss and a promise to fight again another day. When a terrible joke is the only bridge between horror and necessity, gallows humor is a show of respect for the work that lies ahead. I'm glad that my friend David did what he needed to do that night to treat every patient he'd see that was going to come through those doors after that delivery boy died. And I'm glad it still bothers him. Thank you.
I'd be curious on a more practical level how your committee or this department or whatever structure it is within the medical school, how that functions kind of on a day-to-day operational basis. Do doctors come to you with problems, or what does it do, you know?
Sure. So there's two distinct things. There's the Medical Humanities and Bioethics Program, which is part of the medical school, and then there's the Medical Ethics Committee, which is a hospital committee. And those are very separate organizations, so I'm going to answer both of those things. The program that I'm in serves a teaching function. So there are ethics and humanities courses, and what's very unique about Northwestern is having both and having them integrated. Some schools have really strong bioethics, some have strong medical humanities, so it's very unusual to have both together, and that there are required courses in those fields all 4 years, right? So that's unusual also. So we're doing a lot of teaching in the medical school and course creation for our students in training and consulting with our colleagues in other disciplines who ask for our assistance in developing anything or supporting anything in their science-based curriculum. The Medical Ethics Committee is for practicing physicians in the hospital, so physicians will call, or any nurses, a patient, anyone who's having what they conceive of as an ethics issue can page the committee and get a consultant to come talk with them and maybe do a full-blown ethics consultation to help them work through that problem. Same way you would call a palliative care consult or an orthopedics consult. You say, it's not that I don't know anything about ethics, but this is a really complex situation. I need some extra support here, or we have a disagreement in our team, and we need someone to help us work this out. So that's how that works. In terms of gallows humor, that's interesting. People sometimes ask me, well, when people come to you with these stories, blah, 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 this is backstage. I'm not hanging around backstage hearing these jokes. No, people don't page the ethics committee being like, I want your opinion on a joke, like that. You notice I refer to my friends because I have these stories come to me when occasionally a student or a colleague will say, let me run this by you. I feel uncomfortable about this. And they're looking for some sort of confirmation or sounding board. Does that answers your question? Great. Someone had a question over here? I'm going to make Jesse run.
First off, thank you very much.
You're welcome.
It was really helpful. And
Good.
you had commented that we've come a long way in how medical students treat cadavers and the profession supporting their experience and having an opportunity to look at their own behavior and feelings. And I wanted to, if you're not aware, to let you know there's an organization that addresses how physicians and nurses utilize humor in the profession, called the Association for Applied and Therapeutic Humor.
Interesting.
And
that's a whole different field. This is sort of like, this is very gross categorization, but sort of there's patch atoms and then there's the jokes that can get you fired. And it sounds like you're on the like therapeutic and positive.
I wouldn't agree with that.
You wouldn't? And you,
no,
okay, good, thank you. That the division's not so clear.
No, though Patch Adams and that crew certainly exist within the discipline, I think there's also a real attempt to look at not only how it's applied therapeutically, but how the therapeutics also reflect on the physician and the provider.
Wonderful.
And that part, and how it's done ethically and appropriately and not abusively.
Fantastic. Thank you for letting me know about that. Sorry. There's that down here. Okay.
Another question about the ethics committee and how it works in the medical center. You are asked to consult, as you mentioned. Are regular rounds made by the ethics committee in the critical care units?
In some institutions, they are.
Right.
In ours, at different points, there have been regular rounds. There isn't now, to my knowledge. So is there a statement behind that? Do you think there should be? Have you had experience with that?
Well, I've been in an institution where we did do that.
Wonderful. I think it's a personnel issue. I think
Right.
in a world where we had the staff, we would think institution should have.
Because
Yeah.
those would be the areas
Yeah.
where there would be the most, obviously the most need, one
Yeah.
would think.
I would love to see that. I think it's a great idea, and I think it's kind of a staffing funding issue.
Thank you again. Do you have any clergy that are part of the ethical
we have
committees?
just amazing hospital chaplains. We have amazing hospital chaplains, period. And then some of them sit on our ethics committee. Yes. And this gentleman had his hand up.
Two questions. One is there a sort of a successor or heir to House of God in sort of more modern literature? And two is, I'm really intrigued by you working with Second City, and do you tie that with your medical student teaching at all, or do you ever come across medical students you think should probably do improv as a career, or vice versa, find improv artists who should think about becoming physicians or something?
As a good attorney, I'm going to take the fifth on whether I think some of our medical students should shift careers. No, I never find that. So I teach law and medical ethics and medical humanities. Like that's my main gig here. But I do teach this doctor-patient communication through improvisational theater as part of a humanities selective. So to this person's question, students at Northwestern are required to take a short humanities course in both their first and their second year, but they get to choose from a long list of what they want to take. And so I offer one of those. So using improvisational theater techniques as a doctor-patient communication is a way in which I bridge that. I would also just say everything I've learned in directing and performing and writing is applied to my teaching and my work here. So I don't see them as like, I don't see it as schizophrenic as sometimes people think. I think there's a flow, between them. And your first question about the modern successor, I don't know what it is. I would love it if other people had thoughts afterwards and want to come up and tell me what it is, because I haven't identified it, but I think the rules of humor have changed. I don't think it would be as successful. I don't know if publishers would jump on it. I could be wrong. And maybe it's migrated to television. And so House and the impaired physician who says terrible things about patients has become this other outlet for it. I don't know if there's a novel. I don't know if there is. I think we have time for two more questions. One more question. I'm getting this. And then this was, what? Was this? Oh, we have a ton of time. We have a ton of time. This doesn't end at 2. Oh, we're going to be here all day. Let's do this. All right. I'm sorry.
First of all, this is the first time I've heard anyone talk about this subject. and it's enlightening.
Good. So
But-
you don't object to the backstage thing and bringing this front stage?
Right. But how many episodes of MASH have we watched?
Some.
A lot. And I'm just wondering if you think that that was a forerunner to what you're talking
Oh,
about.
absolutely, absolutely, and it was a combination. So if you're going to do the family tree, you know, soldiers have Catch-22, you know, doctors have House of God, and then their love child is MASH, right? So you get war and medicine, you know, examined in that same way. So absolutely, I mean, it's part of, I wouldn't even say forerunner, it's just part of this long tradition of that, but a wonderful example of it, sure.
To quickly answer that, the question about House of God, actually, I think St. Elmo's Fire was based on House of God. And yeah, it was, I had a question about, you mentioned now the way that we approach cadavers and respecting cadavers is different than, you know, we used to, where before, you know, you would like pick up a foot and like tap your, you know, colleague with it or something. And I'm sort of, you know, I have this, one part of my opinion is that when it comes to medical doctors, part of you just wants them to be like a mechanic. You know, like you can do your job with very like technical skill and precision, and maybe you don't need that, you know, them to feel too emotionally involved with you, you know, in a way. So do you feel there's any drawbacks to the new way of handling the cadaver, you know, that sort of experience?
Well, it's interesting. So you're saying from a patient perspective, you want your clinician to be more like a mechanic. And so for the, I don't see a drawback to this except, unless if we taught our students, now every patient, you gotta sit down and become their best friend and blah, blah, blah. You know, they have to be able to gauge, and part of the communication skills, if I've got a patient, not I, but if someone has a patient who comes in and is like, much more like, okay, I'm gonna make my decisions, I don't need your hand holding, blah, 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 then to be able to respond to that, honor it and respect it, and have a, and this goes to the Second City question, the performativity of the role of doctor, figuring out I'm not in every scene the same way, right, if that's what the patient needs. So I don't see a problem, a downside to this if it's taught well. Like anything, if it's taught poorly, because there's a lot of people who would say, like, yeah, my insurance changes every year. Trust me, I'm never going to see you again. You know, I don't need to forge this big bond. Other people really need it and want it, and it may change if you're there for a pap smear versus you're there for your, you know, ongoing chemotherapy. You might have a different desire for your relationship.
Oh, hi.
Hi.
I'm actually a nurse here at Northwestern, and I just think I'm hearing you, it sounds like you've got a very warm perspective of bringing, you know, humor along with illness.
Not necessarily. What's your experience?
Well, I guess as a nurse, I worked in oncology for about 4 years, and I had to leave because of this overwhelming feeling of, I felt bad about myself if I would try to be lighthearted around the patient and not, you know, go down this dark road with them and try to expel all their feelings. And I just wondered, do you feel like doctors are at more of an advantage of using humor because they are not necessarily with the patient quite as much, taking care of the emotional needs quite as much as nurses? Can
I ask you a follow-up? So you said you felt badly using humor, like you felt like it would be inappropriate?
Absolutely.
Right. Well,
it's strange. Like I almost feel like with nurses, there would be, I don't want to say that there's competition. There's not competition, but I always felt like you are a better nurse if you are more emotionally affected by the patient. So you are more compassionate. You are a more warm person. Where if you can stand back and use humor, you're not as nice.
Right.
And I just wondered if that's.
Yeah. So I wonder if that's, I mean, you raise a fascinating point that's so complex, and I'm never going to be able to do it justice. Off the top of my head, I would say, I wonder if there's a gendered aspect to that, like the idea that the women are mostly nurses, or the nurses are mostly women, rather, and so this idea of like how do women, the performativity of nursing, that you're a jerk if you make a joke, you have to wear your heart on your sleeve and show you're super nurse and you're really so involved in that, and that becomes this cultural construction within your backstage culture, where you judge each other and say, oh, she's not so good, she made a joke, right? You judge the backstage norm that is enforced, right? So you're describing a backstage norm that sounds like, A, it didn't work for you, and that's just completely valid regardless of that, and then it sounds like you have a critique of that as a norm for everybody, that there should be more of a range of opportunities for different nurses with different personalities, different reactions to different patients, different needs of different patients, to have a more broad repertoire in how they handle
Right.
that. So I don't know how much is gendered. You make the point of the temporal nature of someone who's with you all the time versus someone who comes in, you know, for a shorter period of time. I think
Right.
that could play a big factor, and that power differential. So if as a patient, I'm eager for my doctor to have a quick peer moment with me, that feels really validating.
Right.
But with a nurse, maybe it feels distancing if I already perceived her as a peer in a different way because she's holding my hand while I'm vomiting, you know, through this chemotherapy.
Right.
Maybe it actually makes a distancing thing. So there could be so many things going on there. But if that way of performing nursing and in that particular discipline wasn't right for you, you were right to move on.
Right, right. I mean, I still work with, I'm outside of oncology now. I work with
right.
stem cell transplant patients are
Fantastic.
autoimmune diseases, but the imminence of death is not there, so I'm able to deal more effectively in that role. So it's better.
Great. Let's take some questions from this side of the auditorium. We like them better.
Kind of to piggyback on this nurse, what she said, I think there, maybe I'm wrong, but there might be different areas where, you know, people like me who are naturally funny and sarcastic would not be good in, maybe, you know, oncology, but, you know, OB-GYN or some more happy fields of medicine. What do you think about that?
There's potential for that, but I also think patients are different. If I'm delivering a baby and a nurse is cracking jokes, boo, you know, that's not funny, potentially, right? It raised to mind, I see my sister sitting here, which reminds me, I cut my thumb really badly. I'm so lucky, I've had so few encounters with the medical profession, because I'm healthy. I mean, I see them 5 days a week, but I turned the shower thing, this old porcelain knob, and it broke, and it like just gashed my thumb open. It hurt, it bled, you know, and I'm a complete baby, so I'm like in the emergency room to get stitches. And a medical student was stitching it and doing the anesthesia, which was new to her, she shared with me. And like the anesthesia, the number of needle sticks were so much more than the number of stitches I was going to have, and it hurt. And I was, you know, it's kind of, I'm fairly tough, but then there was something liberating about just sobbing my way through this, you know. And backstory, a lot of stress, whatever. I'm very tough. But I was crying in this moment, and the nurse said to me, she goes, "Have you ever had a baby?" And I was like, "No." And she goes, "Well, I recommend you don't." I'm like, and what was so fascinating to me, my sister was with me because I had called her. I'm like, I'm in the emergency room. And so my sister's sitting there, and my sister, there's a pause, and my sister goes, "Hey, that's not nice." And was very defensive of me, and later said she thought that was so terrible. And the funny thing was that I took it as a joke. I thought the nurse Tough Love was trying to joke with me to break me out of my crying. I had a question of why it was wrong for me to cry. Was it for her benefit? Or was she you know, I see people with stop signs through their heads, lady, you know, shut it. But I took it, I laughed, and I was like, well, you know, and she's like, there are a lot of good ones out there for adoption, you know, and went on about how I should never have children, you know, and I thought it was funny, but my sister was very upset and just thought there's nothing funny about it. She was totally inappropriate, and you know, just was I appreciated the mama bear defense of me in the moment. But it was interesting. So in terms of when you say the different professions, I think it's probably profession-based, but it's also patient-based. And if you lose that, that's part of my improvisational training of you don't know in an improv scene who's going to come through the door, you know, what the person will be playing. Think of that of patients. Don't look at the chart and think you know who's coming. Let them tell you who they are and what they need, you know?
Back to your thumb and your sister's reaction.
I still don't have total feeling back. I'm not going to lie to you. That was 2 years ago.
Which is maybe kind of minimal. That is the nurse's remark, but sometimes, rarely. But
would you raise your hand? I actually cannot tell who's speaking.
Sometimes,
I'm sorry. I was so confused.
Sometimes medical personnel really go way off and can be offensive. Is there some sort of bureau operation place at your institution, a complaint department?
The Bureau of Joke Censorship?
Well,
No,
sometimes I imagine doctors, nurses may just say something that sorely offends the family.
Yeah.
What should one do?
So there's a patient's representative department at our hospital, and I imagine at every hospital, where you could call with a complaint, or, you know, that's not an ethics consult kind of thing, but you just call and say, I do not appreciate the way I was treated, and trust me, they get calls every day, right? And so, I mean, at every institution, I'm not saying at our, you know, they get calls. People have disagreements, people have complaints, and so that's who you would call, and they would sort of serve as an intermediary, either just if it's a simple thing of like, I need to speak to that professional and let them know that wasn't appreciated, they might want to recalibrate in the future, or if it's something like they need to make an apology or have a sit-down conversation to clear up a misunderstanding. So yeah, there is a patient's representatives department for that, to make sure patients are empowered if in the moment they can't talk about it themselves. They have an institutional person to be their advocate, so absolutely.
Hello.
Oh, is it someone? Yes, ma'am.
Thank you for your insight and your perspective. I so appreciate it.
Good.
I'm quite interested in knowing if you have used Dr. Moreno's concept of psychodrama in your classroom, and if you could comment on the its possibilities in terms of humor and educating. It's been used, of course, as therapy, but it's a very exciting and old but goodie.
Yeah, I'm familiar with it in the context of therapy. I've never tried to use it. I would think of it certainly at this point as outside of my expertise, because I think that's a method, if used poorly, you know, can lead to bad consequences. But I'm intrigued by your comment. I think there is a role for it, and it's not something I've used. Thank you. Hi.
After thinking about this, I don't even know if I want to make this comment.
Ooh, that means we want to hear it, right? Right. Yes. Yeah. Please do.
I had a very good friend of mine. I'm not going to tell that she's a relative, so I'm going to just say that she was a very good friend of mine. And she worked in the emergency room at a hospital in Chicago. I'm not going to say it was Mount Sinai. And she had this lady that came in basically every Saturday night. For like 2 months she came in, and she was always trying to commit suicide. And so after 2 months, the nurse got tired of it, because they had to pump her stomach, and then they had to go through all the things, you know, she had to fill out all this paperwork. So after 2 months, when the lady came in, after that time, she came in, she said, look, come here. And she, you know, she did everything that she had to do as a nurse. She said, let me give you some advice. What you need to do is that you need to get you some sleeping pills, maybe about 5 or 6. Then you need to put a plastic bag over your head. Then you need to open up the oven and make sure that it's an old oven, and then you need to blow out the pilot. Take the pills, put the plastic bag over your head, and put your head in the oven, because I'm tired of you coming in here every Saturday night. So after about 2 months, because she told us this, and we were like, oh my God, she told the lady that. So we asked her, we said, what happened to her? She said she stopped trying to commit suicide. She left her husband, whatever she was. She got a divorce, she had her kids, and she went and got a job. She was bored, she wanted attention. And evidently she needed attention, but she got tired of her, and I thought to myself, oh my God, can't you lose your job for telling somebody like that?
Yes. That would be the patient complaint department we were discussing. There would handle that one. I want to question how your friend knows this woman's trajectory and outcome with such detail if she didn't come back to the emergency room. Did she come in with flowers like, thank you for kicking my ass? She came back to visit.
She was the only nurse because evidently she had been going to other hospitals.
Uh-huh.
She was the only nurse that she had encountered within a year that told her that.
That spoke with her straight. So that told her that, like, about how to do it. Okay, so I love that. You know, that's a wonderful example of it. Someone from frustration just being like, ugh, I can't do this. And we can see, like, people are laughing, but there's this also like, oh my gosh, this person is doing repetitive suicide attempts. Why aren't they inpatient in a psych ward? Why aren't they getting treatment? Why aren't they getting medication? What's going on with them structurally, you know, like socially and circumstantially that's, you know, why aren't they getting treatment? So from this, and so think of the Freud's external obstacle. If the nurse's frustration is the ER should not be triage for people with severe and ongoing mental illness, that should be handled otherwise. Did that joke of saying, patient, I'm sick of you, subvert sort of an anger and frustration? Should have been system. Why are we not treating this patient, you know, in the right way? She deserves such better care. Why? She shouldn't be here. If she's here every 2 weeks, we screwed up, right? So there's that element of it. But from the peer relationship issue, it sounds like the patient had a response which was like, oh, you're talking to me like a regular person. You're not just patching me up and passing me out, which is what the emergency room generally is supposed to do, right? Patch up, either go upstairs or outside. You know, this is what we do. It's our job. And so if she kept getting turfed outside, you know, that nurse was able to say, look, something's got to change. Now, in terms of the underlying depression issues that lead people to multiple suicide attempts, I'd be really surprised if that joke, you know, it's going to put some pharmaceutical companies out of business if that's all it takes, right? So I would love it. I would love it if that were true. But it sounds like there's a lot of complicated things going on there, but that's a wonderful example of exactly what we're talking about. So thank you for sharing it and keeping it so anonymous. Yeah, this is our last question.
You had mentioned the front stage and backstage of the medical practice, and it seems that a lot of other professions have this front stage and backstage. Mm-hmm. When you have the accidental overlap, whether it be accidental or intentional, you have the overlap, and it's kind of where the ethics comes in, whether or not it's right or wrong. But do you think it's vital in the ethics courses, do you think it's important for them to enforce keeping the front stage and backstage separate? Or do you think there's some sort of benefit to having an accidental overlap?
Well, you ask a great question. I mean, so front stage, backstage, just because it's happening backstage, first of all, it doesn't mean I think it's okay. When people huddle together and be like, oh, it's just us? I have some horrible homophobic, racist joke to tell. You know, like, what are you talking about? It's just, that's I don't want to, that's terrible. I don't want to hear that, right? So the fact that it's backstage doesn't make it just clean it up. And if you wouldn't say it front stage, it's an interesting gut check to say, so why am I saying this? Is this actually an appropriate thing to say? I think sometimes the front stage opening it up is a little helpful. I'm kind of a sunshine fan, so it is helpful because it clears out some of those cobwebs of those things where maybe they shouldn't be said at all. But I'm also sensitive to this role issue, that there's things, if every time I leave the hair salon, the stylists are like, look at Professor Dork a lot, you know, who doesn't want to have bangs or whatever. You know, I don't need to hear that. Like, that's not going to help me to know, you know. So in the backstage or the teacher's lounge, the way they might talk about this kid I'm never going to have, you know, if they were talking about that child, you know, in a way they would never talk about it at a parent-teacher conference or say to my child in the classroom, does it really hurt? You know, that's fine with me for them to have their backstage thing if it helps them get through these irritating children all day, you know? So I'm not sure, maybe there's a little help of bringing the backstage front stage, but I'm also not sure it's necessary. I'm just more interested in are good things happening in both places. Great. So it sounds like on that note, we're going to wrap up. Thanks so much.